a new topic in oral medicine and radiology, that is red and white lesions. So these are the lesions which is commonly seen in our oral cavity. It could be a white lesion, it could be a red lesion. So there are various categories in both the categories. Some are precancerous lesions, some are non-cancerous lesions. So basically, a white lesion is an abnormal area of oral mucosa which is appearing whiter than the surrounding tissue. Okay, so it appears a little bit more whiter than the adjacent tissues. So why this white lesion is forming, or why it looks like a whiter lesion compared to the surrounding mucosa is because of hyperkeratosis, that is increased thickness of epidermal covering, or it could be due to the imbibition of fluid and coagulation of fluids and formation of pseudomembrane, and there will be a decreased blood supply. So all these reasons could ultimately result in a white lesion. Okay, so this is the first one, increased thickness of epidermal covering with increased production of keratin. So this is a keratin which is supermost the top layer. So there is increased production of keratosis, which is known as hyperkeratosis, which could be a reason for the appearance as white. And the second one is benign thickening of stratum spinosum. So we have various layers: stratum basale, stratum spinosum, stratum granule, and stratum corneum. So the thickening which is seen in stratum spinosum, and there will be accumulation of fluid and intra and extra cellular region, and there will be formation of pseudomembrane, that is the pseudomembrane formation. So all these could result in a clinical appearance of a white lesion. Now red lesion is area of reddened mucosa that may be smooth and atrophic looking, or may exhibit a granular or a velvety texture. So this could be due to reduction in number of epithelial cells, and also could be due to the increased vascularization. Okay, so there will be atrophy, that is reduction in number of epithelial cells. The classification of red and white lesions. So we have red and white lesion with precancerous potential, then keratotic lesions with no increased potential for cancer, variations in structure and appearance of normal oral mucosa, non-keratotic white lesions, and oral candidiasis. So leukodema, photoisis, granules, and linea alba, they are the normal anatomic structures which is present in the oral cavity, which are the variations in structure. And in non-keratotic white lesions, the habitual cheek and lip biting burns, uremic stomatitis, radiation mucositis, Koplik spot, mucous patch, and oral candidiasis. Oral candidiasis could be classified as acute and chronic. And keratotic lesions with no increased potential for cancer, they are stomatitis nicotina palatii, frictional keratosis, white spongy nevus, psoriasis, keratosis follicularis. Whereas red and white lesions with precancerous potential, they are leukoplakia, erythroplakia, carcinoma in situ, palatal changes associated with reverse smoking, OSMF, lichen planus, and keratosis congenita. So this is a classification of red and white lesions, and we should study lichen reactions. They are a family of lesions with different etiology. So the reason could be different, but they appear as, that is, the clinical and histologic picture is common. So in lichenoid reactions, we have lichen planus, lichenoid contact reactions, graft versus host disease, and lichenoid drug eruptions. The first one is lichen planus. It is a chronic mucocutaneous disease of unknown cause. This was described by British physician Erasmus Wilson in 1869. Because lichen means fungi, planus is flat, its appearance is like a flat a flat appearance. It is distributed in oral mucosa. And the etiopathogenesis could be, it is an autoimmune disease. It could be the changed keratinocyte, which presenting as antigen, and it is affecting CD4 and CD8 helper cells, which ultimately causes basal cell apoptosis. So this magnitude of underlying subepithelial inflammation determines the types of clinical appearance. So there is cell apoptosis. So what is happening at the subepithelial level determines its clinical appearance. So if it is a mild degree of inflammation, it could be due to epithelial hyperkeratosis, and severe inflammation, there will be partial or complete destruction of epithelium, that is atrophy, erosion, and ulceration. So these are the various types of oral lichen planus: reticular type, papillar, plaque, atrophic, erosive or ulcerative, and bullous lichen planus. So reticular lichen planus, it is fine white lines or striae. It is known as Wickham striae. It is seen as a network of circular patterns. Can see the white striae, Wickham striae here. It is commonly bilaterally on buccal mucosa, sometimes on lips and vermilion border. This is plaque-like and this is papule-like. This is homogeneous, well-demarcated plaque surrounded by striae and may appear as clinically similar to homogeneous oral leukoplegia. And atrophic, that is homogeneous red areas seen in buccal mucosa, palate, and gingiva. And most disabling form is fibrin coated ulcers surrounded by a erythematous zone, sometimes displaying white striae. This is erosive or ulcerative type. This was plaque and papule type. The cutaneous manifestation is not just seen in oral cavity, it is seen in hands, such as pruritic erythematous to violaceous papules, seen in trunk and flexure surfaces of arms and legs. Trauma may aggravate the disease, which is known as Kopner phenomena, which is a short note. What is Kopner phenomena? Which is the trauma which aggravate the oral lichen planus, which is commonest extraoral mucosal site involved, genital mucosa. Okay. And diagnosis is presence of papules or reticular components, which is a striking feature of OLP. It may exist along with plaque-like erythematous or ulcerative lesions, and biopsy and histologic examination is required for final diagnosis. So investigation in histopathologic, we can see the sore-tooth retapex, and liquefaction degeneration of or necrosis of basal cell layer, eosinophilic band, which is just beneath the basal membrane, and dense infiltrate of inflammatory cells such as lymphocytes and macrophages. In immunofluorescence, it looks like this. Now we'll move on to the management. Treatment strategies are limiting the progression of disease, reduce the exacerbation, and relieving the symptoms. In diagnosis, we have history taking, examination, biopsy, and elimination of other contributing factors: alcohol, tobacco, poor processes, poor oral hygiene, amalgam restoration, medications. So if it is non-erosive or asymptomatic, we need to just follow up. If it is erosive or systematic non-erosive, we need to start the topical steroids. If they have the full response, we just keep the steroids in regimen and we need to follow up. If there is no response, we need to think of systemic steroids and do follow up, if provided that there is no contraindication to use steroids. If contraindication to steroids, we need to think of topical cyclosporin or tacrolimus. So this is a treatment regimen for oral lichen planus. So corticosteroids we need to topically use as a gel or mouth rinse 2 to 3 times a day for 3 weeks, then taper during next 9 weeks till a maintenance dose. So we need to reduce the doses and 2 to 3 times a week is reached. Okay, so maintenance dose of 2 to 3 times a week is reached. We need to taper the dose. Systemically used as 1 milligram per kilogram body weight once a day for 1 week, followed by a reduction of 10 mg in each subsequent day. So topical steroids we have 0.05% fluocinolone gel, which is 2 times a day for 2 weeks. Then clobetasol gel and triamcinolone, dexamethasone elixir. Then topical anti-fungal therapy. Other topical agents are calcineurin inhibitors such as cyclosporin and tacrolimus, retinoids, and UV phototherapy. So differential diagnosis, it could be lichenoid contact reactions, drug-induced oral lichenoid reaction, GVHD, that is graft versus host reaction, discoid lupus erythematosus, or bullous membrane pemphigoid. Now we have drug-induced lichenoid reactions. They are skin eruptions which occur after ingestion or inhalation of certain chemicals. So they represent a delayed type of hypersensitivity, which is a type 4 hypersensitivity. So pathogenesis, we consume the drugs. So proteins it's a haptens which act as antigens and perceived as foreign objects by the T cells, and there will be immune reaction. Okay, so drugs could be penicillin, gold, or sulfonamides. So clinical features, it resemble as lichen planus, but this drug-induced lichenoid reactions are predominantly unilateral. Okay, the other one is bilateral and present with an ulcerative reaction pattern. Management, the first thing is discontinuing the drug, and then symptomatic treatment with topical steroids. Lichenoid contact reactions, they are considered as a delayed hypersensitivity reaction to constituents derived from dental materials. So all the etiopathogenesis is almost same as a previous lichenoid drug reaction, and which is also resemble oral lichen planus. The clinical difference between oral lichen planus and lichenoid contact reaction is the extension of lesion. Okay, and management is replacing the dental material, which will result in cure or improvement in most of the cases, and most lesions should be expected to heal within 1 or 2 months. And we have GVHD, that is graft versus host disease, is a common complication of allogenic bone marrow transplantation. So here what is happening, the immune cells in the transplanted marrow recognize the recipient as foreign and mount an immunologic attack. It is like autoimmune. So the transplanted marrow will be considered or recognized as a foreign material, and immunological attack will be there. Clinical features, they are indistinguishable from oral lichen planus but are more widespread in nature. Skin lesions are present. Management is topical steroids, fluocinolone and clobetasol gel. Treatment of opportunistic infections like candidiasis and development of secondary malignancy has been recognized as a complication of this. So that is all about red and white lesion. It is just addressing the lichen planus and its lichenoid reactions. We have various lesions in red and white lesions. So we have seen the classification. So they are we have leukoplakia, erythroplakia, OSMF. Leukoplakia, OSMF, you can find the videos which were uploaded previously, and OSMF, lichen planus, and leukodema, fordyces granules, linea alba are the normal anatomic appearance. And oral candidiasis also, another session is uploaded in the channel, so you can go through it. So this all comprises red and white lesions, not just lichen planus. So I just covered lichen planus and lichenoid reactions. So I'll come up with a new topic in dentistry and more. Thank you.